Echocardiography is done from the chest wall in certain regions where the lung does not overlap the heart very much. You know that air in the lungs will reflect sound or ultrasound, so that the views of the heart will not be good if lung is overlapping the heart. That is why we get poor echo window in emphysema. So the common views used in echocardiography are those where the lung overlap is minimum. For example, this is the parasternal long axis view. It goes from the base of the heart to the apex. And if you place it the other way around, this becomes the parasternal short axis view. These are the two commonly employed views initially. Then from the apex, you can have sweep from the apex to the base of the heart, and this can also be multiple views: 4-chamber view, 2-chamber view, and 3-chamber view. Those can be obtained from the apex. Next view is from the subcostal view. Subcostal view is very useful in two situations: when there is emphysema and the heart is pushed down, and subcostal view will become much better compared to parasternal views where the lung will overlap the heart in emphysema. So in emphysema, one of the best views will be the subcostal. Another situation where subcostal view is best is in congenital heart disease, pediatric evaluations. Pediatric cardiologists often start from the subcostal view, and they use an inverted view, or what we adult cardiologists say as inverted view. They will say that is the true anatomical view. When you view from the apex, you know that it is inverted, but when you use inverted view, that becomes the normal pattern, and they are more used to that inverted views. And the next view is suprasternal view, mainly for the aorta, descending aorta, arch of aorta, and suppose there is a ductus or coarctation, that can be better imaged from the suprasternal view. Rarely other views can also be used. Right parasternal to see the right atrium or a dilated right ventricle. Then you can be a view can be taken from the liver region, especially in postoperative patients where the central part is covered by dressing. Then you have a view from the infra axillary region. It's very useful for evaluation of inferior vena cava. In postoperative patients, we know that volume status assessment is very important. For that, if the central part is covered by dressing, then you have to go by the infra-axillary view towards the right side. Then you will be able to see the inferior vena cava well. All these views may not be obtained in every patient. It depends on what you are looking for. Then we'll view some of the video clippings commonly used in adult echocardiography in a normal color Doppler echocardiogram. Parasternal long axis view is obtained by keeping the transducer in the left parasternal region where the lung does not cover the heart, with the beam of the echo transducer going from the base to the apex. So it is a slice from the base to apex. You can see it moving now. This is the interventricular septum, and I'll freeze that view for you. This is the interventricular septum, right ventricular outflow tract, and anterior surface of the right ventricle. The chest wall and the position of the transducer will be here. And this is the aorta. Aortic valve is in the open position. Left atrium. Mitral valve is in the closed position. And this is the posterior wall of the left ventricle. Papillary muscle. Cross section of the descending aorta. Here you can see it. And here you can see the papillary muscle, chordae, anterior mitral leaflet. You can see the aortic valve there. Now the color Doppler is there. I'll go back a bit. In color Doppler, flow away from the transducer is depicted as blue. You can see a mosaic color here, multicolored. This is a tiny mitral regurgitation jet, which can be there even in normal. And this is blue flow again. If you look at it, you can see injection into the aorta was seen as red because it is towards the transducer. Now we are seeing it live. This is another view. This is the M-mode echocardiogram at the level of the left ventricular cord. This is the movement of the left ventricular cord, anterior movement in diastole and posterior movement in systole for closure. This is the movement of the right ventricular anterior wall. Chest wall will be here, and this is the posterior left ventricular wall. You can see that it becomes closer together. Septum moves towards the left ventricular cavity, and posterior wall moves towards the left ventricular cavity in systole. And it is diastole, it is the other way around. This is diastole. Ventricle relaxes and expands. Uh, right ventricle, interventricular septum, chordae. This is a parasternal short axis view, which has been labeled right ventricular outflow tract, cross section of the aorta, pulmonary blood flow by color flow mapping. You can see that it is predominantly bluish color because it's going downwards away from the transducer. This right ventricular outflow tract. This is the circle and sausage appearance. This is the circle cross section of the aorta, and sausage is cross section of the pulmonary artery because pulmonary artery curves around the aorta and goes posteriorly. And you can see the bifurcation, pulmonary artery bifurcation. In congenital heart disease, we identify the pulmonary artery by looking at the bifurcation. Vessel which bifurcates will be the pulmonary artery, while vessel which does not bifurcate, aorta does not bifurcate. Aorta usually has multiple branches in the the arch of aorta. And posterior to that aorta will be left atrium, and this will be descending aorta. So if a PDA is there, it will be in this location. And you can see a tiny pulmonary regurgitation jet there. I'll show it back again. Please and go back. Rather tough to time it exactly. You would have seen a tiny jet going backwards. Observe this region. Yeah, that is the tiny jet. And this is the cross section of the left ventricle and right ventricle. This is circular. The other one is semilunar. And this is left ventricle and right ventricle here. Interventricular septum. Tricuspid valve in closed position. Mitral valve in closed position. Interatrial septum. Right atrium, left atrium. This is the apical four-chamber view, where all the four chambers are seen just as what we learned in school classes. And you may note that the interatrial septum, a portion is not seen. That is because echo beam is coming parallel to the interatrial septum. So when the beam is parallel, a thin portion, this is the region of the fossa valley, will not be picked up well. So This is a false dropout in intra-atrial septum, which is normal. But if you see flow across in color Doppler, then you can know that it is not a false dropout, but a true atrial septal defect. The mitral leaflets are opening, and this is the suprasternal view, arch of aorta and descending aorta. In congenital heart disease, it is important to see this view to avoid missing a coarctation of aorta. If there is a coarctation, there will be narrowing here, and a very high velocity jet will be seen in this region. We'll go back. This is the blue color descending aortic flow. You can see the descending aortic flow. This is the suprasternal view. Very important in congenital heart disease. So these are the most commonly used views. Subcostal view is another view which we have not discussed here.